I think since the time is short, we'll move on to the next talk here. This is going to be this is going to be the real world experience in DME, and Dr. Mallika is going to give this talk. Dr. Mallika, please.
Good morning, everyone. It's nice to.
Dr. Raja, so you are going to moderate both real world things. Why don't you come over here?
I'll be speaking only on my experience with cases and not anything else. See, though it's a Bayer session, I think ultimately we are only discussing what is best for our patient, because ultimately that's the only thing which counts. Is it happening? Okay, can you convert it to full? कर सकते हैं आपको आता नहीं है तो छोड़ दो फिर चलो छोड़ो okay so I'll be talking about my own experience. So the previous speaker has already touched upon the strength of effect and the long duration of action. Here I would add the zero adverse events which we see with of cataract, raised IOP, inflammation with brolucizumab or biosimilars, and contamination with bevacizumab and the Indian steroid formulations. And it has gradually become the first line drug in treatment naive patients, as everybody was saying here, because of its best response in shortest time. And we know that early anatomic improvement will give the best visual outcome long term, because it prevents damage to the retinal cells, drill, etc. And the long duration of effect reduces the treatment burden also, which is not only cost but also the risk of infection and endophthalmitis. So this patient is to demonstrate how a treatment naive patient will behave. We injected him in January, and in March, you see 2 months later, the vision has improved significantly, as well as the anatomy. We did inject at this time, and you can see that 14 months later is where he had a recurrence. He continued to improve, had very good reading vision of N8, and then only at 14 months after the last injection, he came back with a recurrence. So that's the duration of effect with the aflibercept. And the visual results are often superior to the anatomic results. Now, this is a patient who had ranibizumab earlier somewhere when he came to us. So we started with aflibercept in 2019. So with one injection, you see the marked improvement in his vision. And this was bilateral case, so he was very happy. We re-injected him at 3 months, and then again at 3 months. And then you can see that there was a marked anatomical improvement as well as structural. At nine months also, his vision was so good, 9 months after the last injection, that he refused to take an injection. Though we said that the edema had recurred, he refused to take it. He agreed only after 12 months of the last injection, because there was a slight drop in vision. And after this injection, even the anatomy was good at 6 months, and he came back only after 10 months agreeing to take an injection. So 10 to 12 months was our duration of effect. Long treatment intervals. Visual results are superior to anatomic results, and near vision or reading vision improves much more than the distance vision, which most of our patients really need if they are working. This patient is to show a DME which this is usually what we see, which does not respond to anything else that we have at this time. So this is a patient in 2017. For 1 year, 1.5 years, we treated him with IVTA because of financial constraints every 3 months. And there was some response. So 1.5 months of IVTA. They stopped responding to IVTA, so we treated him every month with IVTA. But even with every month, we were not getting a response now. So we spent 1 year in that. Then we shifted, he agreed to take a DEX implant, and this showed no result. Even at 2 weeks, you can see the response. So we tried 2 DEX implants, that didn't work. So finally he agreed for aflibercept, and at that time the ILIA for You program was there. And you see the immediate reduction in the thickness and visual improvement, which lasted for 3 to 5 months. So after that, for the last 2.5 years, he required injections every 4 to 5 months. And since October of last year, he has not required any injection. When he came last few days back, there was no edema with good vision. So response was superior to steroid implant, lasted long, and earlier switch could have given him a better visual acuity, and that's how we have shifted it to our first line treatment rather than as a last line. Now, very important, which I have been working on recently, is how hard exudates respond to drugs, any drugs. And this is a lady with hard exudates. Um, you can see how she improved within 2 months. The hard exudates have resolved, but she could not come for treatment because she developed COVID infection. And when she came back, you see how much of exudates have increased. But again, we repeated twice at 2 month intervals, and you can see a marked resolution of hard exudates. So aflibercept is effective in the treatment of exudates if it is given properly in 2 to 6 weeks, sorry, 2 to 2.5 months. Steroid is not a default therapy for hard exudates. Resolution happens fast, but long treatment intervals will allow progression of exudates. So this is another patient, bilateral. You can see 2 injections given at 3 month intervals, and at the 6th month you can see the marked resolution, at which time we did laser. Another patient, we injected just one injection in December, and by February you can see both eyes, the hard exudates have gone in each eye. This is to show when a patient doesn't take the injection, then you can see the increase. Here you don't see well because they are fine exudates, but at 6th month, because the patient did not take an injection, the increase in exudates, he was so comfortable with his one injection that he refused to take at the 2nd and 3rd month. And finally, the effect of aflibercept in a vitrectomized eye, which does not change in a vitrectomized eye, just like a steroid. So here you see in January, we gave an injection and the patient was very good and came back only more than 2.5 months later, which is its usual duration of effect compared to a DEX implant. Thank you.
Thank you, Dr. Mallika, for showing excellent cases. You have given
you.
real food for thought for everyone, and how we can. We'll have discussion later. I think I call upon, because since this is a real world experience on DME, I call upon Dr. Bhuvan Chanana for his talk and share his experience with real world cases.
इसमें तो है, ये तो हो जाएगा, वो वाला दो। बेकार है ये, पोडियम बेकार कि वो करना पड़ेगा।
So very good afternoon to all of you. I'd like to thank AIOS and Bayer for inviting me to this session. And I think we have discussed all the important points regarding the use of anti-VEGF in DME. So probably my real world experience will just say the same thing. So I'll be presenting a series of 4 to 5 cases, 4 to 5 different cases, and how they responded. So the first case would be was an old case, a 50-year-old male around 2018 when aflibercept was just introduced. His vision was 3/60. The patient received 2 ranibizumab injections. However, the vision did not improve and there was no reduction in the macular edema. The patient was then lost to follow-up for about 3 months and did not have any improvement in the vision, neither in the macular edema and OCT. That was the time when I first used aflibercept. This is one of my first cases, and after 2 injections, the vision improved to 6/18, which was sustained with treatment on aflibercept. The vision improved to 6/12, and the OCT also gradually improved. So after that, I became more confident in using aflibercept, and I started using them in treatment naive. This was 2019. They also came up with the reduction of the cost. So this is a treatment naive case, and we all have seen that there is presence of diabetic macular edema after 2 aflibercept injections, the vision improved to 6 by 18. So again, I maintained this patient on aflibercept PRN regime, and the vision improved to 6 by 9 after 3 aflibercept, and after 5 aflibercept, the vision was retained. So now coming to case 3, this is a case of drill. There is some intraretinal cyst, there is disorganization of the inner retinal layers. So there is some macular edema is also there, but the inner retina could be seen. So I gave aflibercept, the vision improved to 6 by 18. After 3 aflibercept, the vision further improved, and the foveal contour also became much more normal. So this is the same treatment on a treat and extend regime after 7 aflibercept. The foveal contour has remained better. Somehow I don't know, initially which I thought of drill was probably not drill, but also that also showed there was more clarity now in the retinal layers. So drill usually should not improve. So probably it was not drill, or probably some mild improvement in the drill. So this is another case in which there was presence of a chronic diabetic macular edema. After 3 aflibercept, there was no improvement. The vision improved by 6 by 60, and at this time, since there was no improvement, I decided to give him a steroid implant, and after 4 weeks, the vision improved, and the macular edema also resolved completely. There was a recurrence of the macular edema after 4 months, and a second Ozurdex implant was planned, and now the patient is stable at a vision of 6 by 18, and after 12 months. So now coming to my last case, this was also a non-responding case. After giving 3 aflibercept, the vision did not improve. So again, I decided to give a steroid implant, but this patient denied. Since the patient was in the patient support program, he said, I want to receive my rest of the injections. And after giving 5 aflibercepts, the macular edema resolved on its own. So probably this was a slow responder. I would like to really know how to differentiate a non-responder from a slow responder, because I think most of us make our switch after about 3 injections, or probably even after 2 injections, which have been, people make it early now. So the patient is stable and is on a extend and observe regime, and after 9 aflibercepts, the vision is pretty stable at 6 by 12. So just thought, before giving anti-VEGFs endlessly, we should look at the anatomy, presence of any hard exudates, increase in the presence of macular ischemia with increase in the FAZ. So these are the cases which will not improve. This was one case in which has received probably 12 or 20 of anti-VEGF, but the vision is not improving. So this is an octa showing an increase in the FAZ. So this is just the take-home message. I think the most important thing is the control of the systemic status, which has been highlighted. A regular checkup should be encouraged. Good counseling should be done. Control of the hypertension, anemia, diabetes status of other comorbidities is very important. And according to protocol T, I think aflibercept has been proven to be one of the most superior anti-VEGF agents in vision less than 6 by 12. And in vision, if it is better than 6 by 12, then probably it results in faster resolution and lesser number of injection, which has also been highlighted in the previous presentations. So intensive treatment is the key for the management of diabetic macular edema. I think in the initial period, that will not only reduce the further injections, but will also reduce the overall treatment burden on the patient. And it is important to rule out the anatomical alterations, presence of hard exudates, macular ischemia, to counsel the patient beforehand. So thank you all for your kind attention.
Yeah, thank you, Dr. Bhuvan Chanana, for the nice cases, and also Dr. Mallika Goyal shared some very nice cases which were resistant to earlier treatments of whatever agent they were giving. So it boils down to, the same questions repeatedly probably we hear, but is there any new insight which our panelists can give today? Ashish is raising his hand over there. So, Ashish, if I can ask a question, then you can also give your comment, maybe related to my question. Yeah, yeah, yeah. So, the question is, do you still use ranibizumab, or you always start off with aflibercept? And if you use ranibizumab, I'm not saying biosimilar or innovator here, when do you switch to aflibercept or any other agent? Ashish? Yeah, so do you use ranibizumab? And
Yeah, primary therapy because of the financial reason. Otherwise, I would start with 50%.
okay, and when do you look to switch in terms of how many injections or what OCT criteria parameters would you look at?
Means with every injection, I should see a response. The
Okay.
point I should know, I'm not seeing the response. That is my change.
Is
I
it
should
after
see
one
some
injection
response.
you
Even
don't see a
yeah,
response?
yes, even after one injection, if I should see a response with my therapy, even
Very
with one
good.
injection.
That's something, I would say not new, but at least something different. Dr. Mahesh, how many are you? The first question is: are you still using ranibizumab, or if yes, when do you look to switch?
I am using ranibizumab for the same reason like what Dr. Ashish mentioned. So if when I would switch is probably 3 to 5 injections later, but I would, like Ashish mentioned, I would look for some change in the edema, particularly in naive patient. Some change in the edema, I would continue. Frequency of injection increases, or if it stops responding and the vision has not improved, is when I would switch.
So even if after one injection you don't see any improvement, you are willing to switch.
No,
Is that what
I will not.
you will not switch?
Like probably 2 to 3 injections is when I would. If there is absolutely no change, is not when we switch.
So, Dr. Hemant, in terms of switching, like we just now discussed about ranibizumab to aflibercept, but that may not be the necessary sequence anyone uses. So, if let's say you have used ranibizumab in a patient, uh, do you ever consider switching to, let's say, maybe dex implant or brolucizumab without considering aflibercept, or do you necessarily go stepwise, aflibercept, or is it dex implant and then looking for the next agent?
No, when I see that there is no response to anti-VEGF, especially let's say the patient is pseudophakic, so I also look into the other factors.
Can you
And-
specify the anti-VEGF you're talking in this
Let's say
particular?
we start with the ranibizumab.
Okay.
Let's say that's what primarily is used because of cost reasons. Now, if they fail to respond to that because it's in the same group of drugs, and I feel that it's pseudophakic, I would try to put in a steroid implant in that situation. But if it is phakic, I would change over, switch to an Eylea or something like that, aflibercept as a switching drug, provided I see no change. But
So
I
that-
would probably look into other factors before I really say whether I continue with another anti-VEGF or with a steroid.
So basically, you're looking at the lens status basically to decide on the other choice
And
other
the
than
glaucoma, if the patient has a large cup or has some changes in IOP or borderline IOP, I would probably not use steroid as the switching drug, probably change to aflibercept.
So, so George, I would like to give one information from a study we are doing at LVP right now, and then I'll follow up with a question. So, we have looked at 50,000 patients who have received anti-VEGF injections, but not DME alone. It's a whole broad basket of indications. What we found out that patients who pay out of pocket, self-pay patients have 42% compliance rate for the first injection advice. They come for the first time. Insurance patients 100% compliance for the first time that they come. But then among the patients who come for the second visit, a lot of dropouts happen between the first and second visit. But those who do come for the second visit, the compliance, if I advise another injection second time, it is 80%. So 42% the first time. The second time it improves to 80% among those who come. A lot of dropout between the first and second. But do you consider this durability? At what stage do you start looking at the prolonged duration of action? Because anti-VEGF usually you have to give monthly in the first. So, at what stage do you start looking at this durability of action? Given that now brolucizumab and now faricimab is also going to come, at what stage do you start looking at it?
No, this is only after the initial good response. What you're saying, after the second visit, they become more compliant. That's because that's a time when the vision starts improving. See, after the first injection, we already discussed about when to switch. So the consensus from academy says 3 to 4 monthly injections and at least 50% of the excess thickness reduction. That is one of the guideline which you asked. So even she showed a beautiful case of late responder, wherein after the third, after the third injection, started responding beautifully well. So the late responders are there. So that is why after the first injection, if you take a call on switching to steroids or brolucizumab or what, that may be we are looking at something like that's what I wanted to add to the first question. Maybe it's a late responder. To what you said, the after the second injection, the compliance increases, because that's the time, if you look at the peak of vision improvement happens after the first couple of injections. Then you look at like DRCR protocol, whether the vision has maximized. I look at whether vision has maximized or not. After the first two injections, vision had improved from 618 to 612. Almost dry macula. I go ahead with the third injection. Maybe it will reach 6.9 or 6.6 parts. Then we look at the longevity of that. So once you have reached the peak of vision is the criteria, and then not the drying of macula. Vision is the criteria. Then we look at reducing the injection. DRCR protocol says stop it and wait for the recurrence once you have reached the visual acuity maximization. But then I do probably look at one after 2 or 3 months, follow it up with an injection and slowly stop it off.
So, sir, I have a question for you. So, since you said 42% for the second injection, the compliance
first injection is only 42% compliance.
There is a dropout of 42%.
No.
So,
if 100 patients come, first time I am advising anti-VEGF, only 42 take injection.
Only 42.
Self-pay. If it's an insured patient, 100, all of them take.
So that
this is
means
despite the
cost is a
patient.
consideration.
This is despite the patient support program.
This is not about ILR. This is all across self-pay patients.
Because what I observed is, just because of this patient support program, many of my patients, the compliance has increased, because they know that, okay, the next injection, I just highlighting.
Yeah, the second and third, they ask for it.
They ask for it.
They ask for it.
So
Second,
I think
third,
this is something probably with which we can increase the compliance.
Correct.
But different, not even, I think now every anti-VEGF is trying to come with a patient support program. I think these are,
but there is a big gap. There's a gap between whether, if the patient has, first thing, the patient has to come back to you. That's a big dropout there which is happening, and that I'm not mentioning here. But what Dr. George has pointed out from his beautifully answered is that we need to be a little bit aggressive in the first 6 months. You can't delay the treatment, that okay, I will let it linger on, and then later on we will see if further improvement is required.
Just want to add to the PRN is the maximum dropout happening, because you wait for the recurrence of the edema, and then patient gets think that he had a slight improvement after the first injection. If you're starting PRN from the beginning, like what you're asking first, so then patient has a recurrence, there's a high chance of you losing the patient and the compliance.
Basically, I think you have shown a case, as well as Mallika, the real world experience. I think there was a gradual improvement in visual acuity, and the injection went up to 5. And you have shown after that it remained stable and the vision remained good. I think that is the way, if we look at it, that it is not only 3, we talk always 3, but many of our cases, if they are improving vision and getting better, I think because patients, like just now, Dr. Lalit is talking that after third injection, 2 are free. Patient is willing to take that. I'm talking of once somebody is receiving ILIA. But this I have also myself observed in recent time. Not only their vision remain better, their requirement for injection subsequently goes down. I think that is what patient is looking, what we were talking, as far as the durability is concerned, because that is what we are looking, all of us, at that.
Sajay, even if you consider cost, you see our usage of ILIA has shot up after this program came in. When it was 68,000 rupees, you see cost, the total number of anti-VEGFs in diabetic macular edema was predominantly ranibizumab. Now the usage of ranibizumab in DME has decreased to 5% now, and 85-90% is aflibercept. Although data from protocol T and other things are also there, but and from the economics point of view also, you see it is economical now. The cost is very comparable or maybe better also. Plus the longevity compared to ranibizumab, with aflibercept you expect at least 2 or 3 weeks longer duration of action. Plus, if you what George was saying, if you hit hard in the beginning, what Mangat was saying, if you hit hard in the beginning, then the requirement does come down.
So we
So
should not be carried away. We should be clear that recurrences do happen. That's not the same as resistance. So if you have a patient who improves and then it comes back, it is part of the natural disease cycle. So we should not be worried about a durable drug or longevity initially. Whenever there is edema, you have to treat it aggressively. Once you achieve the maximal visual gain, then you can look at the durability.
the concept of 3 injections is more for I think PCV or CNV. For diabetes, we have to do a early intensive treatment for better outcomes, as said.
Yeah, Ramesh and maybe Ashish, I don't know, you had some other point to, but you can, yeah.
Is I might create controversy here. So what is
It's
happening
welcome.
is, so as you first question was, did you have any other insights? So the question boiled down that what is the best vision achieved? That is a question that we always ask. DRC has proved anything which is 2025 or better, in spite of, irrespective of whatever IRF you see, you don't treat it. We accepted it. All the protocols of DRCR in other, even the means all the trials where even monthly injections were given, at the end 30 to 60% patient had IRF. So what we have looked over the time when we published, that these are two different diseases, AMD and DA. So our fluid analysis has to be different. Our tolerance towards IRF should be different in this. So what we published in 2019, based on my experience, single center experience, we gave a protocol called snuff ob. This was in a subgroup of patients who present to you with subfoveal neurosensory detachment. So what we saw from my practice, we gave a concept that, these kind of patients, once you treat them and as soon as the neurosensory detachment flattens and what visual acuity you achieve at that point, then you keep treating those patients forever. Visual acuity does not change. So whether can we tolerate that IRF after, so probably here when the photoreceptor detachment happens and then attachment happens, your limit of achieving 2032 or 2020 goes slightly down. That concept we gave, but we were not sure, how that would fit in terms of visual acuity. Now we have the data of 188 eyes from SNEC, from Milan, from my center. So 6 centers together. Means we have just submitted the manuscript, so I'm just disclosing that what we found. All these patients who present with SNUF, means subfoveal neurosens detachment, if they achieve 2050 or better, you don't treat them irrespective of IRF. Tolerate it the way you tolerate in a normal patient with 2025 or better. If anything goes down below 2050, then you treat them till they reach 2050 or better. Means we are just trying to give another way of,
What is so simple?
So another way of giving a little more of, better financial economics to treat these patients. It will attract a lot of controversies. In terms, means we are just still waiting for the review, but that's what we have seen. So this is another way to look at it.
No, so if you look at all the DRCR protocols, it's in the first 6 months that they have said that don't tolerate any fluid, and you only stop if you achieve 2020. But after that, it's like the same protocol which you're saying. If the edema is stable and there is no 5-letter drop or more of vision, you can avoid re-injections. So once you achieve the maximum visual acuity and the edema is stable beyond 6 months, you don't have to re-inject just because there is edema. And that's what DRCR protocol, at least the later protocol, started doing that. And that's what I would say is, we as DME versus AMD have to differentiate. In AMD, it's not about visual acuity anywhere, it's about any fluid. Whereas in DME, after the first 6 months, if the edema is increasing, you still have to treat those patients.
Yeah, so we are looking at this subset of patients, which consists of approximately 40% cases of your practice. So it means whether ultimately the question boils down, what is the best visual acuity you achieve?
I think the difference between what you are saying and what he's saying is DRCI protocol is after 6 months, irrespective of vision becomes the criteria, whatever maximum. I think here there's no time limit about
No, no,
this.
he also would have a time limit. You can't expect
No,
at
means
1 month to gain
number of
20,
injections.
50.
No, if I go down in terms of my visual acuity, whether NSD is there or not there,
After what time or number of injections?
Yeah.
Because at first
Is
month,
there a time or
is it
injections?
second month,
is our main primary focus here is visual acuity. I do not believe on IRF in
no. So
DME.
actually, let me put it again here.
Okay.
So a patient of 2080 achieves 2050 at 1 month,
Right.
So will you
has some SRF. Okay. Now, what are you going to do? Are you going to re-inject, or are you going to say I will tolerate SRF?
So,
What basis?
So I will tolerate SRF there. I
No,
mean
what-
IRF. I am tolerating
What-
IRF there.
So you won't go for
I
2040.
won't go for that.
How do you know patient is not going to achieve 2040 or even 2020?
That's where we are going to attract a lot of criticism.
Not the
That's
fir-
what I am saying.
So first you need to give 6 months at least for that.
No, what happened? When we have compiled this entire data, that was a striking finding that the potential for these patients after this flattens.
Ashish, you see, there is a possibility that this patient may improve from 2050 to 2040 also.
Or even
I
2020.
agree, sir. I'm not denying that.
Yeah.
I'm
So
absolutely
you can't
not
decide
denying
at
that.
one injection.
What is so sacrosanct about 2050?
Yeah, these were the criticisms will come. So,
What is so sacrosanct about 2050?
so that's what the data says. We talk about the data. That's what the data says. Out of this entire
No, Ashish,
cohort of 188.
Dr. Ashish, you treated these patients monthly in this trial, correct?
No, he says
Sir,
even with
it's
one injection.
No,
irrespective of
no,
protocol.
no. In the existing protocol, you treated these patients monthly.
No, sir, this was not a defined protocol in a prospective basis. So this is a basically retrospective data from the multiple
So
sites.
these patients were not treated continuously.
Means they were
saying
treated
that
the
1
way
month is maximum.
that site
Yeah,
wanted.
maximum.
For example, in India, we would treat it
That
in a
is
different way. Ultimately, our aim was
No
that
way.
what
Prospective
visual
data
acuity
has
was
shown.
there when they achieved first flattening, and what visual acuity was there when their outcome was at the end of 2 years.
No, but if you're treating
I
these
personally
patients-
don't think so that we can, accept this or we can advocate this
Yeah.
at 2050, one injection.
One
you
injection you can't max
you
out.
can't.
You can't say
Because
you are-
So-
because maximization may still occur.
Yeah.
I
You see,
agree.
if after maximization, then it's okay. Then it's
and that
digestible
is-
at least.
that has come from
That is why
prospective studies.
I might create a controversy.
No,
That's what I
that-
did.
From prospective studies. But thanks for bringing up the controversy, basically.
No, retro data analysis may be something different. If prospectively something is done, that's totally.
Yeah, so we came up with concept in 2019. It was published in Ophthalmology Retina, and editor-in-chief said, "Yes, you publish it. I see a value." Then he said, "Prove it." Then now we are at the second stage where there's a multi-centric data. Next would be prospective. What we are expecting, I have written an email to Neil Bressler that please analyze this subgroup in a different way. This is only patients with NSD, that what they achieved. Analyze that subgroup in your protocols of DRCR and see whether we reach to that conclusion.